to this morning session. The topic today is epidemiology of mechanical ventilation, and I would like to do an overview on this based essentially on three aspects, and I will explain right now. This is my financial disclosures I presented to you yesterday, some lecture fees from Hamilton, and a stock ownership and a spin-off of my corporation. So the first part will be the birth of intensive care and the mechanical ventilation, because if we are going to speak about epidemiology of mechanical ventilation, we need to know where, the initiation, where all this start. And in fact, there are some pictures that these are from Bob Kammarek that, I took from him. He was, and this you can see the different people on these iron lungs in the year 53 during the pandemics of the polio. This is also a curious picture in Boston Children's Hospital, which is a multiple negative pressure ventilator. But mechanical ventilation was born, in fact, when, Bjorn Ibsen, took advantage of his knowledge. Ibsen was an anesthesiologist, and after looking at the mortality of these polio people with an iron lungs was around 80%, he thought that maybe hypoventilation was the problem, and he decided to just tracheostomize one patient and manually ventilate it with positive pressure. When he did that, and this is very well explained in this article in Intensive Care, initially did not went well. So it was a little bit of bad feeling in the people there, but as soon as he sedated the patient relaxed, bronchospasm relief, and couldn't ventilate, and then that was the initiation of mechanical ventilation, because they took the students, they tracheostomized patients, they manually ventilated, and then mortality went down. I don't remember the exact figures, but from 80 to 35 or 40%. So, that was the beginning, in that case, of mechanical ventilation. What from them? I will look at first the mechanical ventilators, because then, that was an enormous possibility, for the industry and physicians to collaborate together, and to find a device that could, in that case, support ventilation due to positive pressure ventilation in patients with acute respiratory failure. So there are 4 generations of ventilators, and in fact, it is nice to review how these machines have evolved. The first generations, they give only control mechanical ventilation. So if you want to breathe, so you breathe, but fighting with the machine all the time, limited monitoring, no alarms. They were simply mechanical devices, and there was the first application of PEEP. Here you have an example, also Bob Kammarek giving that photography to me, which is the angstrom volume ventilator. The second generation appears, after the 70s. They can give assist control, major advantage. Monitoring was simple, basic alarms, external IMV through different bags where the patient can breathe spontaneously. And at the end of the period, they were demand valves as IMV or synchronized IMV were integrated. This is the first Servo 900. Probably all of you are more aware on the 900C. That was perhaps one of the best machines we had in the 80s. In the third generation, they were microprocessor control. That was a major advance, increased responsiveness, trigger effort was improved, and there were widespread introduction of pressure ventilator on ICU ventilators. Now we will see if this is widely used or not, the pressure modes. Extensive alarms, expanded monitoring, and the example is the period at minute 7 to 100, where we need to use all these buttons, pressing functions, and so probably, now we have much better machines. And the fourth generation, dramatic increase in number of ventilators at all levels. The introduction of non-invasive, in that case, ventilation modes, waveforms, very important. So we should see how the patient is interacting with the machine, extensive monitoring data provided, upgradeability, and management through assessment packages. And we have had the opportunity in this meeting to see some of these packages, such as PV curves, opening room tools, weaning tools, and so on. And also closed-loop ventilation, because maybe, to develop more and more closed-loop ventilation modes, perhaps can help some patients. You have here only some examples. There are others. But just to tell you that we have all this bunch of ventilators, and then if we want to understand what's going on, or even the epidemiology of mechanical ventilation in our patients, we need to know that in all ventilation, they have different physical capabilities. Here, for example, this is just an example on pressurization delay and triggering delay. If we look at this graph here, all ventilators, this is in milliseconds, inspiratory time delay, you will see that all of them behave differently. So, I think we must understand the machines that we are using, in fact, to also understand the response that the patient has when he is interacting with the ventilator. So the second part is evidence and epidemiology of mechanical ventilation. And I think that these are the major studies on mechanical ventilation when we learn a lot. And in fact, using that studies, we learn something important, that high tidal volume, in that case, is absolutely dangerous for the patients. These two are excellent studies. This is in one center. This is the Amato study. They tested low tidal volume, high PEEP, high tidal volume, low PEEP. So mortality was decreased a lot, low tidal volume, high PEEP. Then these was further tested by the group of the RADS network. Again, same PEEP, but lower tidal volume, much better survival. And then when they tested the PEEP in this trial, the alveoli or the lobes or the express trial, they found that no response, but this has been commented also. High PEEP in patients with RADS, is associated in that case with a decrease in mortality. So, looking at those trials, we have the picture that tidal volume should be low, and in the most severe patients, PEEP should be high, as a simple message. But we need also, in fact, to look at physiology. And this is something that I am the first in, let's say, in that list, but we haven't did that in the past. If we look at this graph, which is adapted, and Villarca, Marek, and Hedenstierna adapted, which is the lung volume as a function of the body weight, you will see that the lung volume accounts for the 63% of the body weight, and this can be the surrogate of tidal volume, 6.3 mLs per kilogram. And this is all the mammal species, and the man is here. If you remember the talks, when the patient in the new, in that case, interacting modes, adapt with the ventilator, usually the patient chooses a low tidal volume. What's the problem on that? That we had never taken into account sites. We are doing sites all the time. So monotonous 6 ml per kilogram tidal volume, maybe is detrimental. When patients start to breathe in these new modes that help, like NAVA, like PAF, most of the time they choose as a routine 6, but they are doing this kind of different, side breathing in the middle. Having said that, when in the late 90s start appearing studies looking at what physicians or respiratory therapists were doing at the bedside. And this is done in Minneapolis, and you will see that they monitor in these teaching hospitals tidal volume, day 1 and day 3, and the year of acute lung injury onset, so through 94, 2001. And here appears the Amato trial. What's going on in tidal volume? Perhaps a little bit reduction. Probably not enough. And here appears the RADS net trial. So it went from maybe 10 to 12 mLs per kilogram, and here maybe 9 to 10 or not even 8, So a little bit decrease. When they look at the same group of investigations at pressures, you will see here plateau, you will see here in that case PEEP, not much different through all these years. If you look at that PEEP levels, initially, first day were low, they increased it a little bit, and here the major difference is that in 2000, PEEP was a little bit higher from the beginning, so something was learned. When I look at that study, which is to analyze epidemiology of mechanical ventilation in the SAPS-3 database, they evaluate the current practice of mechanical ventilation in the ICU and outcomes and characteristics of patients receiving it from that time. October to December 2002. Design, that was a sub-study of this multi-center SAP3, more than 13,000 patients, almost 300 intensive care units, 35 countries. Clinical and demographic data. These are a huge number of patients. You will see here the length of a stay in the ICU. It increases if there is non-invasive or invasive mechanical ventilation. This is significant. I mean, the patients getting non-invasive and mechanical ventilation were more severe, and ICU mortality was around 30% and 35% in that case, hospital mortality. Also, in that paper, they look at that tidal volume and PEEP according to the different quartiles of oxygenation. For example, the first quartile here is PaO2, FiO2 as a mean 100. Here, the second quartile, let's say 200, 300, and higher than 400. And these columns here is PEEP higher than 5, or tidal volume lower than 8 mL per kilogram. And you will see that most of the time, 50% of the patients were out of these measurements that in 2002, as you will see here, probably it was very well known in the literature that we should use maybe higher levels of people lower or tidal volumes lower than 8. But when they look at the mortality according to the PEEP levels, they found something really interesting. It's that patients ventilated without PEEP, I mean the odds ratio for mortality was significant. So no PEEP means increased mortality in any patient being mechanically ventilated in the ICU. So again, a clear message. So where we are. So I asked my friend Andrés Esteban to give me part of the presentation that he did in Bilbao last week on the third international mechanical ventilation study. To me, this is the most important one. So, but I mean, I am not part of them. So this is data of the Andrés Esteban's group. So this is the demographic data. I mean, they collected data in 94, 2009, 98, 2004, and 2010. What they found in 2010? I mean, mean age 61 in that case, SAPS 2, 45, more men than female, and these are the diagnoses. This coma, just a few COPD, and the majority were acute lung injury, as you will see here. When they compare that in 98, 2004, I mean, what they found? A little bit more age here. I mean, patients were a little bit older, a little bit more sick, and also compare with 98, a decrease in the COPD, and again, more or less, same coma. I mean, postoperative, more or less the same. When we look at other causes, I mean, also, it is significant, but I mean, everything is significant with 10,000 patients here. Ventilatory management, more important. Non-invasive, high number, probably, and then we will compare with the other years. The number of non-invasive ventilation failure as a function of the number of patients at risk, in that case, 29%, mean tidal volume estimated predicted 6.9, 8.2, mean PEEP 6.6, peak pressure 23, plateau 19, and days limiting pressure or volume per 1,000 days of mechanical ventilation, this number, just a little bit of proning, sedation and paralytics. But the nice is the comparison here. You will see non-invasive ventilation double each year. 5% 98, 10% 2004, 14% 2010. So this has been, I mean, widely employed. Number of ventilation failure per number of patients as a function of patient at risk, decreasing, which is good. So probably we are much better employing non-invasive ventilation. There was a decrease in the tidal volume, perhaps not sufficient, but a decrease in tidal volume and an increase, in that case, on the mean PEEP, decrease in peak pressure, decrease in plateau pressure, and also an increase in the number of days limiting pressure or volume per 1,000 days of mechanical ventilation. Prone position stay the same, so people, I don't know, but despite the fact that, I mean, there are some data that maybe in severe radiation is beneficial, and also you will see here a little bit decrease in the sedation, and paralytics more or less stay the same compared with 2004. Last one, outcome. Days on mechanical ventilation, 3. Length of stay, 7. Length of hospital stay, 17. ICU mortality, 28%. And hospital mortality, 35. When that was compared, also good news in that case, because you will see here how hospital ICU mortality was 28% compared with 31 and 31 in the preceding years, and hospital mortality also went down. So the conclusion of that huge epidemiological study continues on time with that lung protective strategy are slowly implemented, but not reaching still literature recommendations. So this is something to think why we are so skeptical to implement things that we know that they work in patients. Non-invasive ventilation double its use in all types of diseases, and ICU and hospital mortality has favorably evolved from 98 to 2010. So some good news. But now, more specific, that nowadays, since they are still analyzing the database, we don't know, but look at the most in the 2004. Yesterday, Laurent Brochard explained for 30 minutes all kind of modes we have, but on reality, you have here number of patients, I mean here mechanically ventilated, here in this y-axis, and here the days from the start of mechanical ventilation, and here you have patients ventilated with each ventilatory mode. What's that? This is assist control ventilation. So the majority of the patients, 60%, were on assist control, whereas other modes, pressure control or pressure support, you will see that they are 10% or less. It would be very nice when the database is ready to see what's going on from, in that case, 98 to 2010. But still, we don't know. This is a nice study done in the United States. Okay. Done in the United States, and it tells us an information that is very interesting to common, I think. In the year 2005, more than 6 million hospitalization, 180,000 received invasive mechanical ventilation. Intra-hospital mortality, 34.5, so exactly the same in that case as the Esteban study. But only 31% of the survivors were discharged home. That means that half of them remain in hospital or in dedicated places, you know, maybe for weaning, for prolonged care, for prolonged mechanical ventilation. When they, in that case, analyze the incident per 1,000 population, in that case, they look at specifically mortality and age-specific incidents, they found that with age, mortality increased. But age-specific incidents, as you will see here, increase with age, being extraordinarily high, both mortality and age-specific incidents, when patients are 80, 85, or 90. If we look at something which is the cumulative hospital costs per age group, so how much it costs to ventilate elderly, mechanically ventilate elderly people, I mean, here is known that the costs, I mean, are extremely high in all populations. So the conclusions of that study are some conclusions that, to me, they are not specific to that study. To me, I mean, these conclusions apply to all of us that we are in the ICU. It's that mechanical ventilation use is associated with substantial mortality, morbidity, and resource use in the United States. That could be in the whole world. And efforts are needed to examine the reasons underlying the high mechanical ventilation use at the end of life, and ultimate improved outcome for this high risk, high cost. That means that we need to examine our health system and also our policies in the ICU. I'm not saying that we should not admit those patients, but what I'm saying is that if those patients have no chance to live, then we are doing futility with mechanical ventilation. So we need to discuss more with our team, with the families, in benefit of the patients, in light of these numbers. So the last part of my talk will be, I mean, factors influencing the use an outcome of mechanical ventilation, because now we have a bunch of things. And the first thing is the use of winning protocols. Yesterday, Laurent Brochard nicely, during the winning talk, explained on the role of the winning protocol. So this is a Cochrane review on the use of winning protocols to reduce duration of mechanical ventilation in critically ill patients. And you will see, and if we apply a winning protocol, clearly, in that case, the duration of winning is less, in that case, if we apply a winning protocol. I mean, what does it mean? It means that nowadays, where the human resources are less, and maybe we have, one nurse each 2 or 3 patients, if we have well-designed winning protocols, this will help. Whereas other units that, for example, the study of Rose and studies done in Australia where the nurse-patient ratio is 1-to-1, so there are people there that can interact immediately. The use of winning protocol, it's irrelevant because, everybody is working together. So, compared with usual care, winning protocols can reduce duration of mechanical ventilation by 25%, winning 78%, and length of stay by 10%. These are other results of this meta-analysis. So this can influence the epidemiology of mechanical ventilation. Another thing is the organization of the ICUs. And I took that example because this is quite different across the planet. So the group of Rubenfeld examined the association of closed versus open models in the King County in Washington. So that was a cohort study. What they found, what were the factors in that case affecting survival or mortality in patients? So the ICU model. So the outcome is much better in closed ICU when everything is well organized. And then also the outcome is affected on the severity of patients and on the age. But unexpected, also the ICU model. If the ICU model, in that case, it allows to take better care of the mechanical ventilation, this is going to have an influence. Again, patients on mechanical ventilation, we know some things on synchrony, but it has never been asked to a patient who is on mechanical ventilation how he feels on the machine. Is he dyspneic? Has he air hunger? Is he anxious? And that study, very interesting study, which is now online in critical care medicine, analyzed dyspnea in mechanically ventilated patients. So that was a prospective 6 months observational study, intubated patients, ventilated more than 24 hours. They studied 96 patients, included as soon as they could answer symptom-related questions. So one of these visual analog scale. Dyspnea was evaluated, yes or no, following this visual analog scale, and the script of choice for, very important, air hunger, the need of air, or respiratory effort. When I am breathing, I feel that I am doing a lot of effort. Which is different of the need of air, more air. So they studied 47% reported dyspnea. So half of the patients reported dyspnea. Respiratory effort increased 7, air hunger in 15, both in 16. Dyspneic and non-dyspneic patients did not differ in terms of age, severity, or indication of mechanical ventilation. And then probably we turn to go back to the fact that they are breathing with the ventilator. And each patient is different. In other words, each brain of the patient is different according to the patient wants to breathe with the ventilator. Dyspnea was significantly associated with anxiety, with assist control ventilation. We have discussed a lot on this course on how to improve synchrony in assist control and also heart rate. So an important thing. But it was important, the role of the therapist or the physician adjusting, in that case, the ventilator to relieve dyspnea, effort, or air hunger. Yes, it was. The dyspnea visual analog scale decreases almost 5 points when there was, in that case, a physician adjusting the ventilator. So the most important thing, to grab the chair, to stay there, to adjust the ventilator, and look at the patient, and to ask to the patient if the patient is comfortable or not, together with our understanding of pathophysiology. Also, anxiety decreased, not pain, because pain, is something different on dyspnea, on the mechanical ventilation, which is logical. Again, our patients, Now we discovered that patients on mechanical ventilation, I mean, they are not sedated and lying in bed. And there is interesting information coming from many hospitals that as soon as the patient are able, in that case, I mean, to stay without sedation, I mean, progressively they can go off bed and walk, even if they are mechanically ventilated, as you will see this patient in the Dale Needham ICU in Johns Hopkins, you know. I mean, and this is very important, and this is innovation in the processes in the ICU. So, they quantified that in 45 patients on mechanical ventilation when they, I mean, the objective was assess the outcome of the rehabilitation program, the quality improvement. And look at the data. This is control period, and this is the period after using rehabilitation. Total consultations, in that case, for the physical and occupational therapy, more. That means more people. That means when you start that program, you should ask to the boss or the general director for more people. If not, you cannot start. But other outcome is number of admissions increase. Why? Because the length of a stay decrease in the ICU, the average length of a stay decrease in the hospital, and no in mortality. The study was not powered by mortality. But in that case, the benefit, let's talk about money. Since this program implementation is more than $4 million. So they contract more people, but since they can admit more patients and the patients stay less in the ICU, at the end, if we count everything, I mean, there is a benefit that everybody gets. My final part, clinical decision support systems in mechanical ventilation. Still, there is almost nothing in the literature, but we know if there is ICU staffing, in that case, mortality goes down. And if we have clinical decision support system, we can reduce, in that case, some complications like adverse drug reactions and other things, you know, in a certain percentage. So they are useful at the bedside. And here I'll show you something, just a touch of what we are doing. We have an integrated monitoring system, I mean, in only 3 beds in the ICU because this is still experimental. But this tells us each time that anything happens. Let's say any asynchrony, trap gas, stress index. Well, I presented this yesterday to you. So this is how it looks like. This breath present with a non-triggered breath, and I mean there is also air trapping. And this is the amount of times this happens. Look at this is hours, minutes, seconds. So this patient is presenting all this. So in this, well, it's 4 beds, okay, but with video only 3. That's why I was referring. In these 4 beds equipped with that system, we analyzed almost 5 million breaths, which corresponded to 65% of mechanical ventilation total time. So this is the asynchronous, the total number. So it's 5%, all type of patients, during the whole course of mechanical ventilation. Here we have percent of breath with alarm, and here patients, but trap gas is 20%. So we are now analyzing this data, but I would like you to think, when that happened, during the day. Okay? I just stopped 5 seconds, my talk. Just you to think. In the morning, at night, in the afternoon, when somebody goes there and bothers a lot the patient. Okay? This is the investigation that we are doing. I mean, this is the different alarms, and this is from 0 hours to 24 hours. I mean, this is 0 at night, during the night, during the day, afternoon, and again the night. So usually trap gas and asynchronous go together, but look at that. That patient, you know, I mean, stays more quiet. It is more synchronous with the ventilator, you know, from 8 evening to 8 or 4, in that case, in the morning. So sometimes what do we think on what's going on during mechanical ventilation is not the reality. That's why maybe in the future, and we can discuss after the talk, in that case, see whether this information system that gives us the whole picture of what's going on in our patients could help the manage of them. And I would like just to finish with a picture. This is my team, to tell you that in all these projects that we do, mathematics, informatics, and things, I mean, we need a disciplinary team, and it's a real pleasure to work with them. So, I mean, she's economist, informatic guy, mathematician, informatic guy. All these three are physicians, but this one is anesthesiologist, two intensivists, again informatics, and nurses. Nurses are very important because nurses, we should not forget that they are at the bedside all the time. So we need to teach nurses, we need to provide nurses with contextual information because they are the real actors in patients with mechanical ventilation, at least in Europe. So do not be afraid to work with a multidisciplinary team because it's a real pleasure. I would like to thank to them for all the efforts that they are doing. Thank you very much.